the record button now. All right. Yes, it is going to be starting now. Again, my name is October Boyles. I'm the Chief Clinical Officer with Notes, and Twyla Orr is going to be our presenter today on utilization review for the novice. My part is going to be very easy compared to what she is going to be presenting to you. Now, if many of you don't know Twyla, I have worked with Twyla for a very long time, well over 10 years, and she has well over 14 years of experience in the acute psychiatric setting. She holds a Bachelor's of Science degree from nursing from the Gardner-Webb University in Bowling Springs, North Carolina, and she graduated with Master of Science. And she has also earned her postmaster certificate in nursing education. And she has taught with local universities. She has worked in inpatient, and the thing that you're here for today is she has extensive experience in utilization review. So please give me a warm welcome for Ms. Twyla. Twyla, go ahead.
Well, hello, everybody. Thank you, October, for that introduction. I do want to just say what we are doing today will be very helpful for you if you are new to the role of utilization review. So there are many different disciplines that are able to perform in this role. But most of the time as a reviewer, especially if you're doing verbal reviews, whether you're a nurse or a counselor, a social worker, most of the time you will be speaking on the line with a person on the other end, usually that will have a master's in social work or LCSW, that sort of thing. And then you also will have nurses for the most part. But what this webinar is going to do is to help you get those quick pieces that we know that you need to get your job done and help get those services covered. All right, so these are some of the things we're going to go over today. We will talk about how important communication is with the MCO and also with the treatment team members. Sometimes if you may be doing utilization review if you are providing direct care for that patient, you may be responsible for getting those authorizations as well. If not, then what a scenario could be is, for example, you are a nurse in utilization review and you don't do direct patient care, you will do your best to attend treatment team meetings for your assigned patients so that you have the most up-to-date information and so forth for communication with that MCO. Then we will talk about exactly what kind of documentation you need for the case review. This will very much include treatment plans and effective discharge plans. That's all part of it. And how to manage the case when you don't get that authorization to start. All right, so what is utilization review? Here is a kind of a long definition for you. But what that boils down to is, regardless of your discipline, okay, you are providing healthcare services to a patient, and you are a key member in helping to keep that line of communication going between the provider or facility and between that insurance company. And what you are doing is relaying the necessary clinical information to obtain authorizations for that case. Also, there is a role that you play in helping control cost for monitoring quality of care for that person as well. So for MCO services, here are just a few very basic terms. We have in-network providers, and what that means is for an insurance company, this will be a group of healthcare providers such as physicians, offices, hospitals, and clinics, etc., that will have a contract to provide healthcare services to the members of that insurance plan. The members of that plan would be your patient or slash the customer of the insurance company. Then you have out-of-network benefits or out-of-network services. And what that is, because people do have the right to choose where they want to be treated for their health care. But if that provider is out of network for that insurance company, meaning they don't have a contract in place for services, the patient can still go there, but they will, chances are it's very, very likely that they will have to pay a higher rate for the care they receive. And covered services, those are offered at a certain agreed upon price between the provider and the insurance company that's in network. And this is usually at a lower price than the provider would charge for services received by somebody else who, for example, does not belong to that MCO, or that meaning they are out of network. A service that is not covered by the insurance company will result in basically extra out-of-pocket expense for that patient. So we should do our best in utilization review to help keep that communication with the treatment team and make sure that those services being provided, that the patient can follow through with those. If they cannot, then how effective is that treatment going to be ultimately? And one very big piece of the communication, especially for behavioral health, you have to develop those relationships with these reviewers. And in behavioral health, very specifically, we have a large portion of our reviews that are covered verbally over the phone with that other party, the reviewer for the MCO. And you will get to know those folks over time, because as I'm sure you are aware, there are not many reviewers just readily available for mental health, as there may be for medical. And then on the medical side, they predominantly do electronic reviews primarily. And for behavioral health, we have electronic as well. And the method of you completing your review just depends on what that payer source prefers that you do, okay? So especially if you're doing a verbal review over the phone, just make sure very first that you be professional, kind, and be courteous. That helps kind of break the ice with them a little bit. They're people, and you guys know how times may be when you may not have said the right thing exactly, or something with communication with another person. So you kind of walk away from that with kind of a little bad feeling. You don't want to leave that type of impression with your reviewer, certainly, okay? One of the next things absolutely is to be sure to do is give facts from the medical record. You don't ever want to offer your opinion. You are there to relay information that is documented in that patient's chart, okay? And just keep in mind, most MCOs, especially when you are doing a conversation over the phone, almost always they do record those conversations, okay? And whether it's CMS, the Centers for Medicare and Medicaid Services, or the MCO, they are able to request those patient records at any time. So always be factual. Be professional, and know your case, but make sure that you are giving them not information from your own opinion, but information directly from that patient's chart. That way it keeps you safe, in a safe place. It keeps your organization in a safe place, and you are doing the right thing and doing the best thing to help that patient, okay? And everybody has times where they really want to get that case authorized, but we have to do that in a professional manner. And that is making sure to give accurate, factual information that is documented right in front of us, okay? Also, for telephone reviews especially, most of the time you will already have a prearranged time, unless if you're inpatient, for example, or even outpatient, and you receive a patient for the first time at your facility, regardless of your area, you will not have had a review prior to that because the patient hasn't been there, right? So the first time you will not have an established appointment time to go and talk that case over with the reviewer on the other end. But for a concurrent review, meaning after that initial authorization time has kind of run out, maybe on admission they authorized 5 days, or if you're in like outpatient therapy, for example, maybe they only offered 5 therapy sessions or authorized 5 therapy sessions that first time. Well, but right at the time that 5 session allotted amount of time is going to run out, you will have a review scheduled to complete, and that is what we call a concurrent review, so that you can hopefully continue to get that care authorized for that person and be able to see them through, to their end goals for treatment. So when you have those appointments set with these reviewers, you really want to do your absolute best to be on time. Whether you call the reviewer or the reviewer calls you, that's something that you would have spoken of the first time. So make sure you get all of their information from the get-go. And later on, October will review a template. We have a basic template ready for you already. It's on one of our slides. And you can use this as a basic template regardless of the area that you work in, whether that's inpatient, outpatient, partial. You can use this basic template just about anywhere to help you get through a successful review. So let's talk about communication with the treatment team. This is a very important part, and we have already mentioned that, yes, you do need to attend treatment teams if possible, but the primary part of your information you're relaying to that reviewer is what is documented in the chart. So as far as completing a verbal review over the phone, one thing you can do if you learn some new information in treatment team, okay, one thing you can do is tell the reviewer, well, I came back from treatment team earlier today. I don't have a note yet, but the physician does say he is expecting discharge in 2 to 3 days, or after 2 to 3 more treatments, or something like that. You can make a small reference like that, but just make sure, and you don't do that very much, okay, just with certain things. Make sure that the clinical information that you're giving on that patient's condition, the signs, the symptoms, all of this, none of that needs to come from your own opinion. It has to come from what's documented. And luckily, if you have notes already, some of you may not, but if you do, we are going to walk you through a case study and show you how to pull out certain information from the chart and where to pull that out. If you use other systems, that's okay too. That basic template will still help you and guide you in where you pull out that information. Would just depend on the system that you're using. But back to communication with the treatment team. You want to be careful also and establish your relationship with that team and with that physician. You really, as best you can, you want to try to create a real, just an easy flow type of atmosphere so that you can exchange information easiest or easier, okay? There are going to be times where maybe you don't get that initial stay or that initial round of treatment therapies or counselings. Maybe you don't get those authorized the first time. Well, when you don't get that accomplished as the utilization reviewer, the next step is you have to pull the physician into that case, all right? Then he is then going to have to go and do a lot of the same things that you're doing, they're not usually happy to hear those things, unfortunately. But it's not fun. Everybody's busy. Everybody has patients and things to take care of, but it's a very important piece of patient care. And again, to make sure that that patient can proceed and continue on to whatever that endpoint of their treatment is, so that they're able to reach those goals and continue and improve and just be on their path to wellness. So during the communication with the treatment team, another thing that you really want to try to do is be as helpful as possible. So while you are in those meetings, if they bring up a certain point, ask questions, write things down. Also, be ready with a provider list for the treatment team, whether that's be that you're talking to the physician or the counselors or whomever is a member of that team. They're going to need resources to be able to refer that patient appropriately at discharge. If a person has a whole host of in-network providers, that's the best start. As long as those folks are clinically appropriate to what that person needs, why not help them be able to manage economically as well? And that is part of the utilization review role. So let's talk about that documentation. This is one of the largest parts of your role, being that almost all of the work you do is directly from this documentation. Okay, you have to give supporting information to your case. For example, if you are receiving a new patient for outpatient counseling or even inpatient treatment, whatever the case may be, if you don't have supporting documentation, no one is going to authorize that case. They're just not. Part of them being able to provide an authorization for you is, does this patient meet criteria? And what that means is, are the services that are being provided medically necessary to their particular issue or their condition? Those things are highly important. And if you don't have supporting documentation, you don't have anything to use there to say, yes, this treatment for this person is medically necessary. It meets criteria. You have to be able to pull out pieces of the information that you need, and again, not misleading or embellishing anything. Take that straight from the documentation and relay that to the reviewer, but you do want to help summarize that information as far as, for example, if you have a patient seeking treatment and they have a 30-year history of mental health treatment, well, you're not going to start back from 30 years ago, okay? But you are going to give a brief history, and we're going to see that in a few moments when October takes us through that chart. So a person can have just a multitude of problems and issues over a lifetime or at any given point in their life. But you do need to stick to information that is relevant to that particular case, okay? If a person, for example, maybe someone has PTSD, okay? Maybe the PTSD and something from their childhood, okay, would be relevant at this point. Say they've never received treatment before. They start having a lot of issues. If they've never received treatment, for example, from sexual abuse or something like that, if they've never received treatment, that part of that is certainly and absolutely relevant to their current today presentation. That plays a big role in things. So you have to kind of get familiar with what type of information that you're going to pull from that chart. We're going to go to effective treatment planning next, but just a little bit more about that documentation. For verbal or electronic reviews, your documentation or information you provide is going to be along those same lines, okay? So what kind of information do you need exactly? Okay, one is, what's the diagnosis? We'll start with that. Now, just one thing I do want to point out, very, very many times, especially folks new to utilization review, they will have a reviewer ask, what's the reason for admission? You know, what's the presenting problem? Well, the diagnosis and the presenting problem are two different things, okay? Yes, we need to relay information and what that diagnosis is. But for example, if a person is diagnosed with major depressive disorder, okay, that's the diagnosis, but that diagnosis is not why they had to come into the hospital or why they're having to see you for outpatient counseling. They're having to do that because the problem or presenting problem is, even though they've dealt with that depression for a while, they're taking meds and so on and so forth, they're kind of taking a bad turn here. So they're starting to have suicidal thoughts. They're having crying spells throughout the day. They're having trouble sleeping. Those things are the presenting problem and / the reason for seeking that treatment or the reason for admission to your organization. Okay. So also we have to look at, can these services that are being provided, you know, are those expected to improve that patient's condition? And if you're an outpatient person, insurance companies try very hard to, now, hopefully they will allow admits and so forth when necessary, but the best thing is to keep people out of inpatient admissions, okay? And think about that for just a moment. Inpatient admissions cost a lot more than outpatient therapy, right? So we have to, it's kind of a real fine line in between. Now, at the same time, if you're that outpatient therapist and for whatever reason, your patient is kind of going downhill, okay, they've been okay for 5 years, managing just fine outpatient, but you've all seen those times where you are considering now inpatient admission because they're getting worse, okay, and they're not in a safe place now to be able to manage outside of 24-hour care. We've all seen those things happen for whatever reason over the years. Also, for your documentation, has there been any medication changes? If so, are those changes helping or are those changes causing part of the problem? Those are all important things to bring out with that reviewer. And, even if you're doing electronic reviews, you will always place medication changes. Also, showing medication changes or being able to show medication changes, that is part of active treatment. That's a clear demonstration that people are looking into these problems and trying to help get them resolved, aside from all these other treatments and therapies and procedures and things that we need to help get them better, especially in outpatient areas for counseling or even partial hospitalization where they're not staying in a bed overnight at your place. Are there issues with noncompliance? Is that patient attending those outpatient counseling sessions? Are they attending partial or not? I can tell you, if attendance is a problem, that MCO or that insurance provider will not continue to authorize treatment. Well, because that won't meet criteria because the treatment's not effective. Well, it's not effective because it doesn't have a chance to be effective. The person just is not coming. So all of those things are important. And if you are doing utilization review, one thing that is not on your provided template is, especially if you're in partial or outpatient therapy, for example. One thing that's not on that template for you guys is you do need to keep track of that person's attendance. Okay, if they had 6 treatments, for example, or six counseling sessions authorized, well, how many have they attended so far? Then was that attendance good? Or, did they come regularly? Or have they, if they got 6 days authorized on the first thing, have they missed 4 of them? Sometimes reviewers will give you, I call it credit, but that's not the appropriate term for it. But sometimes reviewers, especially if you have a good rapport, you can say, okay, now, Mr. Jones, he was in a car wreck over last weekend, so he wound up missing his next 3 therapy sessions because he couldn't come. He was banged up. He didn't have transportation. I would like to take note that he's attended 2 out of the 6 treatments, and I would like to get those other 4 previously granted days extended because he has a special situation. Most of the time, they will do that for you, or slash for the patient, but most of the time they'll be agreeable and do that. But if it's a simple thing of just pure non-compliance, you're probably not getting very far with that. Also, what type of changes have there been in their condition? Okay, what is the treatment plan and the discharge plan? They will ask you about a discharge plan and an estimated length of stay or estimated, number of sessions for outpatient therapy and so forth. What's expected, based on this person's presenting problems and according to how many times you expect. Well, they're taking notes of everything that you're saying too, okay? So they will ask you if initially you said, well, we expect their length of stay, for example, if you're inpatient, we expect their length of stay to be 7 to 10 days. Well, that's kind of what they expect too, if not shorter. Unfortunately, that may be shorter, okay? But it depends on what type of clinical information and what type of documentation you have to offer them, okay? So let's look at treatment plans, and we're going to pull up a treatment plan shortly and show this to you, okay? So for treatment plans, effective plans really and truly are very essential to the provision of care. If there is no treatment plan, then how are the staff going to know how to provide that care? What is there to guide them towards that care? Okay, you need to have a clear, realistic plan that needs to be established, and it's not, things are not how they used to be. For those of you who've been in practice for a very long time, like October and I, you all know years ago, it was, okay, this is what's wrong with you. This is what we're going to have you do. You need to do it. I mean, that was pretty much, unfortunately, kind of how that's presented or how they may receive that. Okay. But it was always the providers, clearly. They're in charge. You take orders and you listen and do what we need you to do so you can get better. No, that has gone far downhill now. Things are improving, I have to say, and also this is not only what is recommended as best practice. All of your regulatory agencies pretty much require that. When you have a review or an inspection, any of those things, it doesn't matter what area you're in, okay, inpatient, outpatient, partial, they are going to ask to see your treatment plans, okay? Well, one thing they're going to say is, okay, show me Johnny's treatment plan. And in that treatment plan, if they see, okay, the goal was that, the goal was that he goes to group therapy so that he improves his coping skills, and you're going to show him coping skills and encourage him for therapy and all that so he gets it. So they'll see that intervention and the goal and, the basic plan. Then they're going to look at you and they're going to say, okay, well, thank you for that. Now, show me in this documentation, when did he go to treatment plan? When did he go to group therapy? Okay, well, what was that? What was provided in that therapy session? And then how did he respond to that? Did he attend? You know, if you're not able to link all of these things from your documentation, and something very, very important for treatment planning, the staff as a whole, regardless of discipline, their documentation needs to reflect what is in that treatment plan. Okay, those things absolutely need to match. If they don't, first of all, are you all really working toward the same goal, or are you all on the same path to give that patient the care that they need, or not? You know, again, if there's no plan, how do you know the direction for that care? And if you don't know the direction, how do you know how to get there? You don't. Okay, so you want to make sure that your other documentation, your progress notes, if you had again like an intervention that says, okay, we're gonna encourage him to go to group therapy, or we're gonna give him this type of therapy. Well, did you do that? And if you did, show me that you did. And how are you going to show me? Okay. So your interventions have to be geared to your goals. And what the staff does, that is the intervention. Okay. The goal is what the patient should hope to achieve, and that's in collaboration with the staff. And we all know we have folks that are in different places. Okay, some folks can be extremely active and take ownership in their treatment plans and so forth. And if you are experienced in working with severely and persistently mentally ill folks, then you know there are going to be times where these folks are just not able. Okay, but your documentation needs to demonstrate that. Also, at the point that they're improving some, you know, they can take things in, and, you know, they're clearing up a little bit. Well, then there's the time to get to really get them involved in this. Okay. Also, especially from a regulatory standpoint, for treatment planning, you need to have that patient's signature on that. Okay. That serves as some type of proof that the patient was involved and that was a collaborative process. Okay. So the plan itself has to be specific and individualized to meet what that patient needs for that episode of treatment or that group of therapies that they're now attending. Also, if like for outpatient counseling, if they attended for 6 months and then they come back after a year, well, you can't go and pull that same treatment plan up and expect that to be okay. That is not okay. All right. Every admission or every instance or series of treatments, you know, each one of those series of things has to have their own plans, because that patient and also whether they have the same problems still or that same problem has resurfaced, you still need to start with a fresh plan. Okay, because you all think about just your own life. How much does that change over a period of 5 years? For some of us, that's a lot. Well, that's no different with these folks that you're helping treat. Okay, so we want the plans to be specific and individual. They have to match what that patient is there for. Okay, what was that presenting issue? It wasn't the diagnosis, but it was now, you know, they're having all of these things, all these manifestations, all these behaviors that we're now seeing, and this is interfering with their quality of life. You know, they also have to have clear goals and clear interventions. The goal has to be measurable. It has to be realistic. And that is what your objective is. That's the goal. The goal is your objective. Okay, we want to see Johnny have 0 suicidal thoughts by such and such date, or within, you know, 7 days. Whatever that is, it has to have a specific time on it. Then for the interventions, Okay, so this part is, what are the staff doing to help this patient meet those goals? All right. And yes, patients need to be actively involved as well, but the intervention itself, that is what the staff, that is driven by the staff. Okay. Very, very important. Now, for discharge plans, what does it mean to have a viable discharge plan? Well, there are many different types of patients, many different types of issues for treatment and so forth. Regardless of what the presenting problem was, how long or how fast it takes for them to get better, the discharge plan is one of those important components that you have to have. It has to be a viable plan. Okay, for example, if you are discharging from, let's say, an inpatient level of care, you cannot send, it is not clinically appropriate or safe to send a person that may be intellectually and developmentally disabled, that cannot manage in the world basically for everyday life. Trying to set up a discharge to the homeless shelter, that is not okay, and that's not appropriate. Okay, that is not a viable plan for that patient. Or if it's a patient that is, has a severe mental illness, and they have, one of their host of problems is med compliance and being able to get to appointments and things like that. Well, in that discharge plan, how are they going to get to those appointments, or do they need long-acting injectables to help kind of sustain them over that time period? It has to be viable, okay? And on the other end of that, if you're providing outpatient services already, you have to consider those times when, for example, if a patient is becoming increasingly suicidal, or maybe it's a psychosis, whatever is going on with them. Now, okay, is it time to now consider inpatient admission, whether that be voluntary or involuntary? Then that gets into a whole other separate issue, but you guys know what I'm getting at, okay? So for a discharge plan, we want to have continued goals, meaning we want, still, even though they're released, let's give them some homework to do, okay? Are they supposed to get involved with some type of community support? Do we want them to continue? Okay, Johnny, you've done great. We're so happy you're better. But, we're going to give you a little homework here. We want you to go to this support group. We think it would be so helpful. Is there what can you do to extend that care and all of that for them, so that they continue and hopefully avoid, if from inpatient, avoid a rapid readmission. That's also kind of entangled in those regulatory items as well. But, that's just one example. Avoid a rapid readmission. Or if you're in outpatient therapy, and they are now considered better, where they don't have to attend on that previously scheduled or regular schedule they had, what are we doing to ensure that even though they're now completed, essentially, how do we still prevent decompensation of their condition? Then, do they have a crisis plan in place? Regardless of the area that these patients are being treated in, inpatient, outpatient, partial, whatever the case may be, every one of them needs to have a crisis plan in place. And what a crisis plan entails is, for example, and for those patients who need help with this, for some patients, they are manageable enough and so forth to kind of sit down and make one on their own. A lot of patients are not able to do that, but for an example, and this can come in a lot of different forms, a crisis plan will be, okay, so we'll take a patient, maybe they were admitted due to suicidality or self-harming. Maybe they were cutting themselves, or having the outpatient therapy because they're cutting themselves and things like that. Well, Okay, so what are we doing to ensure as much as we possibly can? We're not there at home with them, right? So as much as we can, what are we doing to ensure that they stay safe after they're gone? Well, one thing is a crisis plan. So, as the patient, if even though I'm discharged, I'm not seeing my therapist anymore. That doesn't mean that I don't have anybody or that I don't have any support. Here is one person I can contact. Okay, so we write that down on the paper. I will call Sally when I start feeling overwhelmed and I want to hurt myself. I'm going to call Sally. Well, what's Sally's number? Well, here's the telephone number right here. We put all those things and lay it out exactly on that plan so they can go home and they can post it up on their wall or do whatever, have that available. For folks who literally have no support, well, then here's part of their crisis plan, and this goes on and on. You remind them of those coping skills. Hey, when you start feeling this way, we want you to do your deep breathing and relaxation. Whatever the case may be. But for a person that has no supports, and a lot of the folks that we see don't have any, all right, for those folks, part of their crisis plan, as far as like a contact who they can talk to when they're feeling overwhelmed, well, hey, everybody in every area has a crisis hotline number or a suicide hotline number. All of those folks are hanging around waiting for the phone to ring. Okay. And, I have to say, unfortunately, most of those people are talking to people 24 hours a day. That's what they do. But you have something in place as a backup. Okay. Now let's talk about peer reviews real quick. This is going to be very brief because this here can be a whole presentation just by itself. Okay. But this is what the steps are, whether you're an outpatient counselor, whatever the case may be. If after that initial review that you complete, you've given the information to the insurance reviewer, and they say, okay, well, I can't authorize any days. Well, why not? Well, it doesn't meet criteria. Okay, so what part of this doesn't meet criteria? And I'm not saying argue, but you need to have a professional way of getting that information. Okay, however it goes, whether they give you a clear reason that you agree with or not, really doesn't matter. Okay, the first thing is when something does not initially get authorized, your part as the reviewer is to then say, okay, well, thank you for listening to the case, but I would like to request a peer review, please. Sometimes, not all insurers. Now, if you have good ones, and that you have a good rapport established with already, that communication's been great. Most of the time they'll say, okay, well, I hate this, but I just can't authorize it this time. Okay, so we're going to have to set you up for a peer review. You'll have some occasionally that will offer that up, but most of the time they won't. Okay, this is your role to say, okay, all right, we didn't get this authorized, so let's set up a peer review. What a peer review is basically is a doctor-to-doctor conversation between the doctor of the insurance company, usually a medical director of some sort, or because they have the authority to turn over that initial non-auth request. Okay, so then the main provider or the attending provider for that patient. Now, if that attending provider is gone on vacation, well, then it's the person that is serving as the attending while they're gone, or whatever that is, but a doctor-to-doctor conversation. Now, just because you ask for a peer review and just because one happens doesn't mean that they're going to authorize the days or the requested treatment. Okay, so just keep that in mind. Now, if the peer review is unsuccessful, the next step, and that would be called a denial. The next step for a denial would be, okay, we're going to start the appeal process. Now, for an appeal, That requires a lot of kind of back end paperwork. You have to send almost everything from the actual chart. Okay, so back to that important documentation we talked about. For an appeal process, you do have to get the patient to sign a waiver for you to act on their behalf. Now, generally speaking, we don't need consents or anything like that between a provider and an insurance company because we're exchanging necessary information to get that patient's health care completed, okay, properly. That does not require a consent, but the part of this that does require the consent is the appeal process really is on that patient's behalf when it comes down to the bottom line, okay? So they need to sign a document saying, yes, that's okay. I want the hospital to do this for me, or I want the outpatient therapist to do this for me. And that means that you can then handle everything. And most of the time, patients will want to do that because many of them don't know what to do or how those things happen. Then they have to get records and all this stuff. So if that step in the appeal process fails, then there's a second appeal. Okay, so a second level appeal will be at your state level, wherever you are. And that's a whole separate process, and it's very long. But your organization will give you the proper steps and what their procedure and protocols are for that. So I have talked plenty enough. I am going to turn it over to October now, and she is going to take us on this case study and show you where to pull out things from the chart.
All right. Thank you so much, Twyla. Thank you. I appreciate you. Really, really good job. Very thorough information. Emily said, is anybody else experiencing a problem with sound? Can y'all hear me? Are you guys able to hear me? Just type yes or no into the chat. Oh, okay. I'm not getting your responses, so I'm hoping. Okay, so not me. Okay, thank you. Thank you so much. All right, excellent. Excellent. So we'll go ahead and walk through the case study. I am going to get into the chart. Oh, a lot of responses. Thank you guys so much. Now, I know that some of you probably have questions, and we are at 3:47 now. We want to be really cognizant of your time. So we want to make sure you type your questions into the chat. If I can't or Twyla can't get them right now, then we will go in and answer your questions for you. We will actually we'll send out answers to the questions. So we do have everybody's email that signed in, so no issues with getting in touch with you. So Ruth said it's from the wind. Okay. Well, Ruth, you must be in a cold place. I'm sorry. I'm really sorry. I can tell you, Twyla and I are currently in North Carolina. It's a beautiful state. So just in case, I don't know if we have any other fellow North Carolina, just out of curiosity, I know because you guys have been sitting here listening, just type in where you're from, just out of curiosity. And if you feel comfortable, you can type in whether you are outpatient, which is OP, or IP. So Florida, oh, Diana, Florida, little jealous. Oh, Miss Teague, North Carolina, fantastic, representing Charlotte. That's exactly where we are. Oh, and Emily, you're in Gastonia? That is very close. That's wonderful. All right. So we do have some North Carolina folks in the house. Fantastic. All of the above, excellent. Alaska, okay. You win, Miss Walker. You win as far as the coldest. So you do. And was Tanya. Oh, fantastic. So we have Shreveport. That's great. Kentucky, Baltimore. Great. A lot of great places out there. Fantastic. We always love to see where our folks are coming from. So thank you so much. That is absolutely wonderful. Twyla, if I can get you to do a favor, can you please sign into your iCanotes account? And then if you could, do you mind flipping to the next slide for me? If you can flip to that next slide, or I can take over right away. I can just flip to mine, whatever works best. Okay, fantastic. All right, thank you so much. So, Miss Test Jones is, or Mr. Excuse me, my bad. Oh, we've got some. I'm sorry, not to be distracted. Michigan, Philadelphia, California in the house. Really, really nice. Yes, and it is very warm right now. So next training in Cancun, excellent, excellent. All right, so on Mr. Tess Jones' account, we have a 54-year-old male, no medical issues, but we do have that major depressive diagnosis, reoccurrent, unspecified. The brief history, recent widower, no children, um, dog passed away 2 weeks ago, father attempted suicide by overdose, and there is a family history of mental illness. So, excuse me, mother completed suicide by overdose, father attempted suicide by firearm. The presenting problems is depressed, obviously, understandably, grieving the death of his wife to cancer 6 months ago. Suicidal thoughts, no intent or plan. We have some crying spells, sleep problems, of course, no social activity during the isolation, and no support system. And then we have a Hamilton depression score of 23. Now, in Icon Notes, you do have the ability to enter in your scores. And one of the really nice things about Icon Notes is not only can we track those scores and trend them out for that particular patient, but we can do it on all your patients. So, right now, outcomes are what MIPS and Meaningful Use CMS is focused on. And so we have the ability, and you're like, how do I pull my outcomes? Well, that's going to be by doing like PHQ-9s and BECS and GADS and the geriatric depression scale, all of those, PHQ-A for adolescents, all of those kind of scales. So, and Twyla kind of touched on this. It used to be, 20 years ago when I first came out of school, if you said the patient was depressed, whether you were a therapist, a counselor, a provider, that was it. They were depressed because you had made an assessment. And now we see this trend, whether we like it or not. And some people have very positive outlooks on it. Some people have negative outlooks on it. Just kind of depends where you are on that spectrum, right? It's a continuum. But now they're wanting you to identify by scales. You saying the patient is depressed, even if you're saying it's body posture, it's attitude, it's facial expressions and general demeanor, they want those scales and those evidence-based scales to do that with. And so that makes it a lot harder on the clinician and the provider, because that some patients don't want to fill out scales. And then we have those patients that they will Google the scale before they fill it out, right? So they want to score better than they're actually feeling. So there's problems with that. But those scales are in Icon Notes, and you're able to chart that and trend that out over time. Now, one of the things that the folks are looking for is, of course, your demographics. You're going to have your name, your date of birth, your insurance policy. That's all of those things that patient information they need to have. You want to review the notes, and then that authorization number. Now, in Icon Notes, we have the ability to go in and put all that information into Icon Notes. Okay, we have that. The whole thing. You're able to put it all into Icon Notes without any issues. Even managed care, one of the nice things about Icon Notes is it will start to talk to you about your managed care units, and it will actually tell you when you're getting down on your units. Say you've gotten so many units or so many sessions, like you've got 10 sessions. Say they're being very nice to you. They've given you 10 sessions. On the second or third session, then you will be able to go in and actually say, you know what, when I'm getting close to the end on that second or third session, send me an alert, and Icon Notes will do it. It'll send it to you. It'll send it to your front office staff. It'll send it to your utilization review coordinator. It'll send it out to all those folks, so you're able to keep track of everything that's going on with Icon Notes. So also in the chart body, you're going to have the initial initial diagnosis, complete evaluation. So you're going to have quite a few things on the chart body itself as far as that. So again, the initial complete evaluation, the medical, behavioral changes, the appetite, the sleep, the precautions if they're on inpatient, the biopsychosocial information, the treatment plan, the discharge plan, the diagnosis at discharge, all of those things you're going to want to have in the chart body. And then, as Twyla's showing you now, that's your basic review template is all levels of care, where the client's name, the date of birth, the insurance policy, admission date, who the reviewer was, the MCO reviewer with their extension number, authorization numbers, dates authorized, admission, diagnosis. We have this all in Notes. So you're able to put all this information into Notes. Even the expected length of stay if you're inpatient. We have flags for, hey, this review needs to be done within Notes. So there's a lot of those things in there that we're able to do and able to show. And then again, of course, the discharge plan. So that's one of the nice things. Now, Big Marker has given me an alert that this webinar is going to end in 4 minutes. So instead of taking you into the chart face, which I do want to do, and we will send you an example of, because in Notes we have these beautiful things called clinical summaries. A lot of people don't use them, but they're really, really nice because they'll take all that data, all that information, and then even pull your notes in from a specific period of time. You can pull treatment plans into it, and you can send that all to that reviewer. And so it's very easy. It's done with one click of a button. It's like 4 to 5 clicks down and you're set. All right. So it makes getting them information that they need very, very good. I did get a question. Can you repeat what alert I can send to the clinician, front desk staff, or UR person? Absolutely. And managed care units, when you're adding those into Notes, you can go into Notes and actually set a chart flag alert. If you're looking at your Notes, it has a nice little flag there. You can set it as a priority. You can pull a chart flag report, which is really wonderful under the reporting sections. We also have on the chart face down at the very bottom a clinician reminder sheet. And that you can put in anything like tentative discharge, or my units are running out, whatever you want about the patient just went on vacation, whatever you want, you have it right there on the chart face. One of the beautiful things about the flags and the reminders is they are not part of the medical record. All right, so it's one of the great things. And then the managed care units, you will put that information in the chart. You can add managed care units into each note. You can turn that on as a requirement if you want, or you can have that send alerts to you to say, hey, this person got 10 sessions and we're now on session number 8. If you want to be one of the cautious people and start sending alerts out at number 7, you can do that, even number 3 or 4. So you have the ability to send alerts on units or sessions. So I hope that answered that question. Again, we're getting a little bit close on time here, but some useful tips and reminders. Again, we can record all authorizations, the MCO's reviewer's name and authorization dates on the medical record. An authorization is never a guarantee of payment. That was one thing Twyla wanted to specify. And do you want to talk about this, Twyla, in case it doesn't get authorized?
Yes, I do. Just one reminder about what that means is when you do an authorization initially and they give you one, it will look similar to what we placed in that template. 123 XYZ, reviewer such and such. Just because they gave you that verbal agreement, okay, yes, we're going to pay for 10 days or 10 sessions. Just remember, okay, part of this comes down to they also have their own auditors and ultimately documentation. So at any time they request those records and so forth, and that documentation doesn't match, well, they are going to take back that verbal agreement. So all of this is done in a manner of professionalism and documentation, accuracy, and yes, I'm giving you this information because it is in this chart.
All right. Excellent. All right. Well, that exactly. You've gone through everything, Twyla, and I really appreciate your knowledge here. I know that's probably been really helpful for folks. Any questions that you have? Because I had to push back the webinar from cutting off on us. It likes to do that in the 60-second mark.
And I am so sorry. Apparently, I have talked too long.
Right.
But also, if in the chat, if you would like to see how, for example, or where you would put an authorization or where you extract a certain item from the notes, please include your first name in that chat and what you would like to see. We can send you video links for just about every step that we have in the program.
All right. Yes, so there is literature. Absolutely, we can send you out literature. If you want to, we have your email. So if you say, yes, I would like some additional literature, and you want to type that in the chat, we'll get that sent out to you. We're not going to ask you to put your email in the chat. We already have it if you signed up to this webinar. So thank you guys so much for joining us today. Twyla, thank you so much for all this wonderful information. And I appreciate you guys coming. I know this is, for a lot of you, this is your lunch hour. So we really, really appreciate you. Thank you. Thank you guys so much. We will make sure we get that information. Again, if you type anything in the chat, we'll get it out to you. All right. Absolutely. You guys have a wonderful day. Thank you. Thank you so much. And Jose, I'll get some information out. Absolutely. All righty. Thank you guys. Thank you. Bye-bye. We'll be